I'm delighted and honoured to introduce Baroness Ilora Finlay. Baroness Finlay is a Professor of Palliative Medicine at Cardiff University, and she's a past President of the Royal Society of Medicine. She's been an independent crossbench member of the House of Lords for almost 20 years. Baroness Finlay has worked tirelessly both in practice and in Parliament to guarantee good care for people at the end of life. She's introduced debates and she championed policy forum, and she's been hugely supportive of our work with people with learning disabilities. So I'm really so very pleased she can share some of her vast knowledge with us today.
Thank you so much for inviting me to present here today at your really important conference. I'm going to talk to you about being prepared for the end of life. I'm talking about dying, making sure there isn't something that's reversible, a bit about symptom control signals, staying at home and looking after someone who's dying at home, and some of the difficult decisions that we have to make. Are there some golden rules here? Yes, go at the pace of the person. Answer all questions honestly, calmly, and simply. Don't talk to them about going to sleep or going to heaven. Be quite clear and honest and gentle. People become weaker and tired. They gently become unconscious, and when deeply unconscious, their heart stops. And they slipped out of life. That's it. If you talk about going to sleep, the poor person will get frightened of going to bed. What about caring for somebody at home, particularly somebody with COVID? There's guidance that I've written, and it's on the Hospice UK website. It's also on the Bevan Commission website. And the link at the top of this slide is the link to this page. And I've gone through here, deciding to be at home, some of the things that you need to think about in planning, things that will arise, how you can tell when somebody's really dying near the end, how you can tell if somebody's dead, and what to do when they've died. But what are some of the symptoms that might arise, or signs that there's a problem? Signs of distress, or if the person who can't communicate perhaps becomes agitated, or they're not moving, they're moving less, or they're just grimacing, their facial expression isn't as it normally is, or they're rocking or humming, making different noises, or that they resist touch, they lash out, they push you away. It may be that they're in pain somewhere, but they have difficulty localizing it. What about the person who's not eating? Well, it's often a sign of nausea, and there may be a reversible cause to the nausea. So don't just think, oh, they've lost their appetite. It may be that they've got something going on, like a urinary tract infection, that's making them feel sick. So think about all the causes of nausea and exclude those, and then deal with the problem. But what has COVID taught us? Well, the old rules have gone. We're in a time of change. Just be person-focused. Don't worry about the old rules. Their oxygen levels, they drop their saturations, but they don't look as if they've lost oxygen transport. So you must do their SATs, because actually otherwise they get critical and they'll just die in front of you, and they may need oxygen. Visiting, don't stick just with policies. Have relatives had COVID? If they have, they're not going to get it again probably. And are there young people in the family who, even if they did get it, they're at low risk and who really want to be the person who visits, perhaps a sibling who's got learning difficulties or an older person? What about vitamin D? People who've been indoors all the time or a lot often are vitamin D deficient. The jury's out as to whether it makes any difference, but it might help them, prevent them getting the infection so badly in the first place. No point giving it when they're ill. I is for infection control. Like any infection, hand washing, masks, keeping your distance. Those are really important. They're the basic principles of infection control. And the D is for do it. Do the right thing for the person. Don't worry about the rules and the policies and the bits and the pieces. The policies are there to keep people safe. They're not to make things harder for people or put them at greater risk of a problem. Listen to what your heart tells you. What can you plan? Well, try to think of every eventuality. Make sure that you've got medication there just in case, a just in case box of things at the weekend or at night that might arise and that you've got medication there. Above all, listen to the person and those who know the person. And if you can, look at an advanced care plan. I want to say a bit about advanced care plans because just like birth plans, whatever you plan for usually doesn't happen. So what if you can't follow someone's end of life plan and their wishes during this time? This picture is courtesy of Books Beyond Words. What is a care plan? Well, it's an advanced statement of wishes. It is not legally binding. You have to revisit it when it's to be used and referred to because it might no longer be relevant. The person may have changed their mind. But it can be a very, very useful document to inform best interest decision making if you have to take a decision on behalf of the person if they can't take it themselves. What about a best interest decision? Well, whoever is looking after the person at the time that a decision has to be made is the person who takes the best interest decision. Of course, you might be able to delay the decision either till the person regains capacity or somebody more senior comes, but actually it's usually whoever's there. And it is that the person lacks capacity for that decision at that time. So they may have capacity for some decisions, but not for others. You must never be motivated to bring about their death. And you must consult widely the family and those who know the person's wishes and feelings. It might be carers, it might be their friends. Again, listen. And think, is there a lasting power of attorney or a court-appointed deputy or similar? Someone empowered in law to take health and welfare decisions. The title of those people varies from country to country. But there is a general principle about the law sometimes putting somebody in charge of decisions for those who can't take them themselves. But whatever decision is taken, it must be in the person's interests, not in the interests of others. It cannot be because it suits other people. It must be focused around the person and only them. And involve them as much as you can, even if they don't have capacity. Still tell them what you're doing, why you're doing it, and consult with them on the little things. You really cannot and must not have blanket policies. And things like the phrase DNAR, please never use it. DNR, do not resuscitate or do not attempt resuscitation. No, that is illegal. You must treat people. They must have all care. Just because somebody thinks that they lack capacity doesn't mean they get less care. But there are difficult decisions that you might have to take. For example, testing. You might be testing for COVID to see if the person is symptomatic. If they are symptomatic, it will be part of their treatment. And therefore it's sensible to proceed because if they have COVID, the way that you'll manage them will be different to if they don't have COVID, accounting for whatever, their temperature, their cough, their vomiting, or whatever. But if testing is because there's a blanket policy in the institution to screen everybody and the person is resisting, then you don't have any right to hold them down and force testing on them. You have to think, why are you doing it? What are the risks? Another difficult decision, transfer to hospital. Know what the policy is about visiting, and on balance, are they better off staying where they are with people coming in? Remember about oxygen, of course, as well. The decision do not attempt cardiopulmonary resuscitation, or DNA CPR, is very specific. It only applies if their heart stops, and all care must be given, including other life-prolonging, such as putting them on a ventilator or using CPAP, or other life-saving care, giving fluids, antibiotics, with COVID, giving dexamethasone, and so on. But above all, what's the golden rule, if there is one? It's to listen. Listen, listen, listen. This is the Chinese symbol for listening. You don't just listen with your ears. You listen with your eyes, and you must be kind. Let the person see from your eyes that you are being kind. Because if you're behind a mask, the one thing they will see are your eyes. And give them your undivided attention. Look at them, stay calm, move gently, and let your voice show that you are really doing things from the heart, and that your heart is behind the care that you're giving. And listen to your heart. Listen to what your inner heart is telling you, and use your mind, the green bit, to integrate everything that you're obtaining to make sure you're doing best by the person. So I've said to you, integrate all of your skills, listen, and listen to that inner voice within yourself. Because if you do, and you're gentle and you're kind, you will provide care that enhances somebody's dignity. They may recover, that would be great, but if they don't, you will have cared for them gently and in a dignified way as they're dying, and you will have done all you can to meet their wishes. And thank you for listening and inviting me. And as I said, as I put on my lanyard, my distance aware lanyard, keep your distance. Those of you that want to use distance aware, you want a lanyard or a button, I'll send the link to you as to how you can get one. But we all need to keep our distance, except when we're in close caring contact. Thank you all.